Good morning.
Morning.
Morning, Kate.
Hi, Janisha.
Good morning, Kate.
Good
Oh, thanks, Bill. We'll get started in just a couple minutes if that's all right, Katie.
Sounds good.
All right, we're at 8 o'clock, so I think we can get started. Thank you, everyone. Welcome to Geriatric Medicine Grand Rounds. This is our Geriatrics Palliative Medicine Combined Grand Rounds today. And we have a wonderful, fantastic speaker, Dr. Kathleen O'Connell, who many of you know. She is an assistant professor in the Department of Surgery, and she is board certified in everything. She's board certified in general surgery and palliative medicine, as well as critical care. And she's the director of the Surgical Palliative Care Service. And you all know her from her work on the Geri T bundle that is used in the trauma unit here at Harborview. That's really innovative and has really improved the care of older adults who are coming to Harborview for trauma, and has been widely talked about nationally. So I'm really, really pleased that you're taking the time to talk to us today, and really grateful for all the work that you do for all of us and our patients.
Thank you, Kate. That was a generous introduction. And I'd like to thank May for giving me this opportunity to talk to everyone today. I chose to discuss CPR and code status discussions with older adults this morning. So I'm just gonna jump right in by sharing my screen. And hopefully you all can see that.
Yep, we can see it just fine.
Awesome. There we go. So I have no financial disclosures to start with, but I do want to make a personal disclosure that I am somewhat of a biased presenter. As a trauma surgeon, critical care physician, and palliative care physician, I often work at the intersection of what seems like a physical intersection of restoring longevity and guiding people at the end of life. And I spend a lot of time and energy sort of trying to wrap my mind around this construct. And although surgeons have traditionally fallen more on like the aggressive side of implementing life-sustaining treatments, And I certainly swing that way when needed. My default approach is on the less is more side of the spectrum. So I'm just going to put that out there because that's the lens through which I'm going to present today. So I have two objectives. First is to review the data on outcomes after in-hospital CPR in older adults. And second is to have everyone log off this Zoom meeting, having made a commitment to make goal concordant recommendations regarding CPR in our older adults. This is the gross outline for my talk today. I'm going to start with discussing what I think the problem is, and then reviewing the data, and then closing out with discussing the approach to code status discussions with older adults. And I'm hoping in that latter portion that this can be more of a discussion with audience participation, because I think that there is a wealth of experience on this call today, and my approach is certainly an iterative process. When I hear something that I like from someone else, I try to incorporate it into my own approach. So I'm going to kick off this morning with some food for thought. And for those of us in palliative care, this self-reflection may be familiar. But I want to enter the discussion with the acknowledgement that we as providers have an incredible asset in the form of clinical experiences that undoubtedly form the cognitive framework from which we begin to imagine how to answer this question, which, if you get the choice, what will your death ritual look like? And I think it's important to recognize that most of our patients lack this experience and really look to us for guidance. And to set the stage, my focus for this discussion is on cardiopulmonary resuscitation as a medical procedure provided to adults age 65 and older who have died in the hospital. And I came across this piece written and illustrated by a palliative care physician at Duke, Dr. Nathan Gray. And he writes, "No matter how long it lasts, those minutes feel like a lifetime. CPR is terrifying, but there's a bizarre comfort in the algorithm. Everyone has a concrete role to distract them from the profound mystery of watching a person die." Again, as a trauma surgeon and ICU physician, I have had my hands on and in many dead people. And this notion of going through the motions of the protocol to protect one's own psyche from the lived experience really rings true to me. So I want to make the distinction between unexpected premature death and versus universal ordinary death. CPR was first conceptualized 60 years ago for acute myocardial infarction for sudden, unexpected, out of hospital cardiac arrest with shockable rhythms. And when you consider all end of life trajectories, sudden death is the least common, accounting for only 5% of deaths. So while CPR is effective in preventing death for patients with sudden cardiac events, it's ineffective in preventing death in patients with terminal illness, progressive organ failure, or pre-existing frailty. It doesn't work as well. So as I was discussing before the call, or before we started the Zoom, I have a 2-year-old who starts every morning with, "Here's the problem, Mom." And since she's incredibly smart and manipulative, she launches into this convoluted explanation of why I should allow her to watch the show Blue's Clues on my phone. So I'm taking a page out of her book this morning. Here's the problem. Critically ill or injured older adults with poor prognosis may receive non-beneficial, potentially harmful treatments, including CPR, because it has become the default death ritual practiced in the hospital. And I think that this should make all of us feel uncomfortable. I define potentially non-beneficial CPR as a resuscitation attempt that is or would be disproportionate to the expected prognosis of the patient in terms of survival or quality of life. And there are several reasons why clinicians are reluctant to provide treatment recommendations with regards to CPR, namely the lack of knowledge about outcomes after CPR, in addition to uncertainty with long-term prognostication, and the desire to avoid infringing on patient autonomy. And so I want to review the latest data regarding effectiveness and outcomes after CPR. Much of what we know regarding in-hospital cardiac arrest outcomes comes from the Quality Improvement Registry Get With the Guidelines Resuscitation, hosted by the American Heart Association. And from this data, we know that approximately 200,000 patients have an in-hospital cardiac arrest annually in the United States. And that equates to approximately 2.5% of patients that are admitted to the hospital. And I just wanted to note also that from Joan Tino's work, we know that 30% of Medicare beneficiaries have an ICU admission within the last 30 days of life. So I think that is very much tied into this topic, essentially, utilizing life-sustaining treatments at the end of life. So I come from a non-medical blue-collar family. And the only way that my family relates to my lifestyle is through medical shows on TV. And the concept of being an intern was particularly confusing. And I must have said, just like on Grey's Anatomy a zillion times while I was in training. But similarly, multiple studies have actually demonstrated that older adults report obtaining most of their knowledge regarding CPR from media, notably television. And so I went looking and found that this list of medical TV shows in the United States, which is published on Wikipedia, and you can certainly see, I started in 1989 because Doogie Howser was a show that I used to watch. But if you kind of scroll down and look, starting really in like the early 2000s, there's a strong uptick in the content that was published or that's been produced in the last 20 years with regards to medical TV shows. And so what's the problem with that? Images on television strongly shape the way that non-medical people imagine illness, end of life, and death. And this study by DM Lantos and Tulsky was published in the New England Journal of Medicine in 1996. And they reviewed 3 popular medical shows in the 90s and found that 75% of depictions of CPR on TV resulted in the patient recovering immediately. And 69% showed that patients were alive long-term after CPR. And furthermore, they found that the outcomes after CPR and television were really dichotomized to either full recovery or death. And so the reality of, sorry about that. The reality of prolonged life-supportive treatments and neurologic disability were really not featured in these shows. And you can see for yourself by these two images that I found online that CPR actually looks pretty good. And I would argue that, especially when it's provided by the one and only Dr. Derek Shepard from Grey's Anatomy. So again, the most up-to-date outcomes data for in-hospital cardiac arrest, plus the use of CPR, is published annually by the American Heart Association via the Get With The Guidelines registry. And as shown here, 25% of adult patients who had a cardiopulmonary arrest and received CPR in the hospital survived to hospital discharge in 2018. And that number has been getting better and better over the past couple of decades, with improvements in medical treatment in the hospital. And I do want to make the distinction that we are talking about in-hospital cardiac arrest, and outcomes for people who arrest out of hospital are actually much different and worse. However, I will say that most of the research on this realm, within this realm, is focused on out of hospital cardiac arrest. So when we drill down to older adults, this study was conducted by folks from the University of Washington, including Dr. Elenbach and Dr. Curtis. And this was published in the New England Journal of Medicine in 2009. And what they did was they used fee-for-service Medicare data from 1992 to 2005 and identified patients 65 and older who underwent in-hospital CPR. And the authors reported that 18% of these patients survived to discharge. They identified folks with older age, male sex, a higher burden of medical comorbidities, admission from a skilled nursing facility, and non-white race were all factors that were associated with worse survival after CPR. Then in 2013, Dr. Chan published this study of long-term outcomes in elderly survivors of in-hospital cardiac arrest in the New England Journal of Medicine. And this study linked data from the Get With The Guidelines registry to Medicare data. And the study consisted of almost 7,000 older adults who had an inpatient cardiac arrest and received CPR. And really the take-home message from this study was that among survivors, 59% survived at least 1 year after hospital discharge. And so that really was the message that the authors put forth in this study. I guess I would say that the way that the data was presented in that study was a little contentious. And in a letter to the editor, Dr. Elenbach and Galvin, authors from the previous study that I just discussed, argued that predicating overall survival estimates on the basis of survival to hospital discharge is actually misleading. And what they did was combine the results from both of the previous two studies and published this chart to describe the overall 1 year survival after in-hospital cardiac arrest. which in my opinion is much more informative for code status discussions with patients. And so as the residents know who rotate through the TICU, this is my favorite table of all time when discussing CPR in older adults. And the way that I read the data and I summarize it is by saying that 1 to 2 out of 10 older adults will survive to hospital discharge after CPR. And 1 in 10 will be alive at 1 year. So if I had to say, if someone's looking for a take-home slide from this talk, I would recommend this chart. So then you're probably asking yourself, well, what if being alive is not the most important outcome to older adults? And in fact, this literature, review of the literature on determining resuscitation preferences of older adults found that most people rated significant physical and mental disability as important reasons for declining CPR. And we all know in this forum that cessation of circulation leads to a significant burden of neurologic disability after cardiopulmonary arrest. This is the Cerebral Performance Category score, and this is what is used to assess neurologic status after a cardiac arrest. Scores range from 1 to 5, with 1 indicating mild or no neurologic disability. 2 is mild neurologic disability, which people are pretty independent with activities of daily living, and they're able to work in a sheltered environment. Scores of 3, which is severe neurologic disability, 4, coma or vegetative state, and 5, or brain death, are considered severe neurologic disability. And in fact, when you look back at the study that I discussed by Chan et al., they report that 52%, or the majority of survivors, have moderate to severe neurologic disability at hospital discharge. So knowing that this is really important to older people, I think it is vital for us to incorporate this into our mental construct and how we make treatment recommendations for people. Okay, so this study was published in JAMA Internal Medicine by Ebel et al. In 2013. This group developed and validated a clinical score to predict neurologically intact survival after in-hospital CPR and branded it the GOFAR score. And the GOFAR score is found on MD-Calc, as shown here. And I just provided an example. There's actually, I think, 13 variables within this score, but you can essentially check the age range of your patient and then go down and check which of the 13 variables applies to your patient. And so you can see here that I checked the age range of 80 to 84, and the only other variable that I checked was major trauma. I didn't add anything else like respiratory insufficiency or a traumatic brain injury or anything like that. But just with that age and major trauma, the survival to discharge with minimal neurologic disability. So the patient is conscious, alert, and able to function independently is is 1 to 3%. And so this tool is a really helpful tool when you're developing your mental construct of your patient, and helps to inform your treatment recommendations. So I want to transition into the approach to having code status discussions, and I'm hoping really to create a space here for audience participation. And I think everyone would agree that the goal of a code status discussion is really to align treatment recommendations with what matters most to the patient or the surrogate. And so I want to open it up, and I hope folks will jump in here. The first hurdle is really introducing the topic. And so I'd like to ask people their opinions on when is it the right time to bring up resuscitation status with a patient. Is there anyone willing to offer what their usual approach is?
Hey, this is Angela from the memory clinic. Can people hear me?
Yes, thanks.
Oh, good. I have fancy headphones in. So I'm in the fun situation of being on both sides of this discussion, because I see people in clinic at all stages of a, dementia diagnosis, which is a game-changing diagnosis, of course. And then I see people on Med-G that were like, we need to intubate now. Is it okay? I just read a chart about someone that needed to be intubated, and the wife said, let me think about it. It's really hard, because I think the language that we have is this kind of, how do I describe it? Like these big, lofty, big topics. But what really happens to people is like they get in a car wreck and they get surgery, or they fall, or of course they're going to go to the ER if they fall, and then of course they're going to get intubated if they are working to breathe. And so, when I'm sitting in dementia clinic, it's hard for me to say, all right, if you fall off a ladder and break 2 different bones, So what I have been trying to do in dementia clinic is have those goals, like what's important. So kind of those 5 M's, like what matters and what is really important to you, and get those kind of wishes documented. But I find this big disconnect between like a checkbox and what people think they want, and then what happens in real life, which just doesn't always conform to these kind of big, lofty life and death checkboxes, if that makes sense. So, we have a lot of people on Med-G who are DNR, but they're getting surgery, and I think that's okay. But then should they get CPR? Well, should they get intubated post-op? I mean, I don't know. I think it's really hard, and I think the situations that older adults find themselves in are really messy and don't always lend themselves to those kind of conversations. It's easy to say, if you were found dead, okay, pronounce them dead, but that's not usually what happens. So I find it really challenging. Anyway, those are some thoughts. I don't know if that helps.
I agree with you, because I think you brought up the great point of like that gray zone of are we talking about if someone has a cardiac arrest versus are we talking about other forms of like life supportive treatments that may be temporary. And I think sometimes that does get a bit confusing when thinking about this stuff. So starting with what is most important to people, their values, their goals in life, that also kind of gets me sort of straight in my mind as well.
Hey, Katie, this is,
Please, after you.
oh, thanks. Hey, Katie, it's Rue. Hey, it's Rue. I had an interesting observation, kind of just going along with what Angela was saying too, about how, you know, the checkboxes that are in a pulsed form, I guess the implications of that and how people interpret that meaning will be different. And so when I am counseling a patient, I'm really using that discussion in terms of an end of life situation. But I've actually observed that there's some variability, I think, in the community to how people actually use those checkboxes. And then on top of that, actually recently, I was meeting with our local station paramedics, and it was actually pretty surprising to me that the paramedics didn't actually know that those different check boxes actually apply to an end of life situation. And so I think we're talking about in hospital cardiac arrest, but some of the issues that I've actually run into in the skilled nursing world have been that I've had EMTs and paramedics actually refuse in some ways to actually implement a care plan that I've discussed with the family and with the patient because of that misunderstanding about those checkboxes.
I have experienced, I guess, a similar situation even in the hospital where you've had the conversation, it's been fully documented. They're not easy conversations with the family. They sometimes take a lot of work. The unfortunate thing happens, and then the ball just starts rolling, even in the hospital, and people don't, maybe they don't know, or it's just so hard to not jump into the algorithm. And that's really, really frustrating, and it makes you feel really terrible
Mm-hmm.
when that's not respected.
Mm-hmm.
It seems that we're living with the consequences of 50, 60 years of cultural evolution in which the default preference was established a long time ago. And we kind of drifted into this situation where CPR is now the default action in all these situations that were not originally intended. So now, because people have these impressions of what CPR can do, it's hard to go back and change that to a different default preference for in-hospital cardiac arrest. So now, I don't know that there's really anything else to do except to build the relationships one by one for people who appear sick enough to die while they're in the hospital, and hope we can do enough of those conversations to head off at the pass the 2.5% who end up dying in the hospital, and we're probably never going to get to the point where we get all 2.5%. And arguably we shouldn't, because we know that some of those people are vitalists, and some of the circumstances occur in marginalized populations for whom the view, even after the discussion, of risks and benefits and burdens may still be, thank you. I appreciate your input, but I still feel that I want everything possible done to keep my loved one alive. And it's important to respect that as well. So it's just going to be messy, I guess is what I'm saying.
David, is it okay if I actually bookmark that point that you just made? Because I would like to, if we, I think we will have enough time to revisit that, because I'd like to get people's opinions on how to deal with those really sticky situations.
Of course.
So, you know, sometimes these are like chip shot conversations, and sometimes, you know, we're dealing with a 95-year-old who's, you know, requesting all these life supportive treatments, and how have people learned to navigate those conversations? I would really like to know.
Katie, can I set you up for that?
Yes.
Wait here.
Yeah, wait,
Go ahead,
sorry.
Nate.
Oh,
Go
no,
ahead.
I was just pointing out, I was just underscoring what David said, where I've had many patients feel as if due to historical, lack of trust in the system, and the fact that it'll be a good chance that it'll be a stranger making that determination about, no pulse, no respirations, therefore on the pulse form, that they just can't at that point agree to a sequence of events that they inherently distrust. So, and I often hear the saying that God makes that decision for me, and so I will not upfront make these decisions on that green piece of paper. So yeah, there's a lot of other subcontext, especially for the older generation.
Yeah, I, in my limited experience with my advanced care planning for surgery clinic, I have come across that quite frequently, especially when trying to discuss, to do anticipatory guidance for potential complications after surgery, and identifying treatment limitations during that post-op period if things don't go as planned. And people do tend to deflect, I guess would be the best way, and sort of their minds just won't go there, and say, I have, full trust in God. I know everything's going to be fine. And, it really does. I struggle with that because it really does kind of shut down the conversation for me at that point.
And Katie, I was going to chime in based on David's topic that he brought up. And in another slant on Angela's comments, I think the reason you're bringing this forward, Katie, is, anytime we personally participate in a code with CPR and ACLS therapy that's not successful, which many of them are not, you get a little PTSD and you think, this was hard on me and everybody present, and we did nothing good for this patient or their family, and it takes you a few days to get over that. But we all find ways to get over that and get up the next morning and try to come in and do the best we can. So that's important. I mean, yes, that is what we're paid for, but it's important to recognize that and understand that we suffer from these episodes. That said, there's really no wrong time to bring this up. And it's, so in clinic yesterday, I had 2 such discussions, and it comes up in the hospital all the time, but it's nice to preface it by asking the person or family, well, have you had experience with being so sick you almost died? Or have you taken care of people who were so sick, or maybe have died while you were taking care of them? Tell me about that. As a way, before you jump right into the pulse form. The new post form, which is just revised, emphasizes the allow natural death side of things, which I think is a better way to bring it up with lay people. Here's what we're gonna do for you: allow natural death, as opposed to do not resuscitate. Here's what we're not gonna do for you. Is a little bit of a better semantic, I think. But that said, when having to make decisions, and you have a different slant on this that's even more PTSD inducing than probably anyone else on the call, and that is, you, as you mentioned, you have your hands inside the person who's dying, a much more cathartic and literally visceral experience of that kind of trauma to us as medical providers. But when they're in the heat of the moment in the trauma ICU, usually these discussions have to be delivered with leadership, consensus, and then documentation. Someone has to step forward and say, I believe that there will be no positive result for doing ACLS therapy on this individual. Forget the statistics. For this person in front of us, it's not going to work. And I assert that we should not offer it. How do you all feel about it? If you have 100% consensus, it's worth documenting that. But the family may have, as May mentioned, may have very important aspects to it. And you brought, your first slide showed something about the ritual. CPR is a ritual. We'd have many rituals in medicine that may or may not do any good. And the value of the ritual may be to the family. If anyone's actually stood at the head of the bed with family members during ACLS therapy, which I've done a few times, it's profoundly cathartic. And in the few instances I've done that, when families have wanted that, it actually did the family some beneficial, there was some beneficial aspect to the family having witnessed that cathartic event. But it was ritualistic. And that needs to be taken into account because we have lots of rituals. I'm getting long-winded here. I'll better shut up.
I know you have to go on, but it looks like Carolyn has her hand up. Carolyn Hurd.
Yeah, I mean, I think this is a good discussion. I think these are a couple of things that I struggle with. First, I want to just say that I struggle with the data. I know you showed that slide. That's your big takeaway slide. And I think that that's helpful. I don't know if 10% is actually for a lot of people all that terrible for the portion. So, and I guess I feel like we should really segment these into kind of three buckets. There are the patients who are very clear, or families who are very clear, CPR is off the table. We don't even have to, it's not even a discussion we have to have. And there's that group, right? The low hanging fruit. Then there's the second group of people who feel like they need more information, right? We can have a conversation about it. We can talk about, we elicit values, we express concerns, and often we'll move to a do not resuscitate in situations where we don't think it's beneficial. It's the third group that is the most challenging, where longevity might be the primary priority, or they've had experiences in the past. And like, for example, we had a patient this week who is in the surgical ICU, who's an older woman who had a perforated bowel, and is on multiple pressors and, is very, very sick. And we did a clear, informed recommendation. And the spouse said, first of all, she had CPR a year prior that he witnessed, and she survived. And granted, that was a different situation. Now she's on multiple pressors, and we talked about what was different this time. But we made a very clear informed assent recommendation to not do CPR. And he really said, well, I'm okay, even with the trauma to her and everything, with a less than 1%, even if there's a less than 1% chance, I don't see the harm in trying. And we could talk about values concordant care, but I think the thing that I struggle with, to go back to the data, is it would be helpful to have more data to really be specific about these particular situations where the multimorbidity, the multiple pressors, the metastatic cancer, those things have been reported in studies as increased risk factors. But it would be nice to see some of those things combined, or a table where you actually look at like, what does that relative risk then increase this to, or that. I think that would also be more helpful, because I think we need to distinguish between what's non-beneficial, which some of us, old language of futility, which would be less than 1% chance, to things that we think would be low benefit. Because that's also slightly different in terms of how we approach things with families who might be on the end of the spectrum of a survivalist, or at least people willing to undergo high burden for low benefit.
Well, thank you all for all of that input. I made a few notes to kind of bookmark and come back to. We have 15 minutes, so I'd like to get through a few more things and then circle back, especially for the trainees who are on this call. I want to make sure that we provide some sort of kind of framework for how to verbalize starting these conversations and what some of us have found works well. My clinical experience in general is usually admitting someone after trauma or with an emergency general surgery problem in the emergency department. And so I think Dr. McCormick brought this up, but essentially I will bring this up at the end of the admission after we have discussed our treatment plan for everything that we're going to do has already been discussed. So when you start talking about this, it's not like we're bringing up we're not going to do anything with no CPR, and so that's typically when I bring it up. And sometimes we can't. Sometimes the clinical situation is such that they need to go to the OR or the ICU. We don't have family around, and it needs to wait. Sometimes it's more important to wait until you're actually in that family meeting, having a bigger goals of care conversation to bring this up as well. And in terms of actual ways to introduce the topic, and I think David touched on this, but what I typically use is something like, I want to switch gears and discuss life supportive treatments with you, or sometimes CPR with you, or resuscitation with you. Some people don't understand what resuscitation means. And really, is that all right? And so there's sort of this like transition point, like you're putting out that sort of warning shot. We're going to talk about something different now. Some people, when you say this, have you given any thought to the type of medical treatment you would want if you died in the hospital? This is just something that I use. I'm sure other people have better things to say. But some people you'll get, yes, I have a living will, or I filled out a pulse form. I talked about this with my family. And then those are like the easy ones, like Caroline said, the easy buckets, where it's just like, okay, you can move on. And then others who say, no, I haven't really given it any thought. And that's really my trigger for trying to figure out what's most important to these people. And again, discussing code status really should take place within the context of identifying patient values and goals of care. And I learned this construct during my palliative care training and use it all the time and teach it to the surgery residents. But essentially what I say is something along the lines of, some people believe that living as long as possible, even if it's on machines, is most important to them. Others say that living independently and taking care of themselves is most important. And Yet other patients tell us that having a natural death is most important to them, and where do you fall on this spectrum? And I love that because it really does allow us to take our own biases out of the discussion and give people free rein to say, well, I fall in between comfort and independence. And then so you can kind of work with that. And then you'll be able to move forward with making a treatment recommendation. And I know that for surgeons, this has actually been studied, and we typically drop the ball at this step, actually making a treatment recommendation. And again, I think that goes back to really the patient autonomy piece of all of this, and feeling like you don't want to infringe on folks what they, if they come in, they say, I want everything done. Okay, well, they said they want to be full code, and I think that that's fine. We're just going to go with that. I would argue that we have a responsibility to ensure that people are informed when they make this decision, and that we're not just allowing their impressions of CPR from television images and things like that to inform such a big decision for medical treatment. And so an example of a treatment recommendation would be, since you would not want to be hooked up to life support machines at the end of life, I recommend that we not perform CPR and instead allow you to die peacefully or die naturally, like Dr. McCormick said. And what do you think about that? And I think that last piece is very important because in the example of the TICU patient, like Caroline brought up, this is just a recommendation, and we should feel comfortable making a treatment recommendation. As surgeons, we do it all the time with regards to surgery. Well, we think, we should do an exploratory laparotomy, or we think we shouldn't do it. And we feel comfortable saying that this person is not a candidate for surgery. But yet we don't feel comfortable making a treatment recommendation with regards to CPR. So there's a bit of a disconnect, and it's a recommendation and people don't have to accept it, which leads into that point about potentially non-beneficial treatments. And are we obligated to provide them when patients and families request that? That's that third bucket of getting, those are the really hard ones. Any comments on that? I do want to just mention the fact that Harborview does have a policy in place with regards to potentially non-beneficial treatments, where if you as the clinician feel like any life supportive treatment is potentially non-beneficial, you are not obligated to provide that. And in those situations, generally getting a multidisciplinary opinion is probably the best idea, and to fully document that.
This is Pam Davies. I wanted to just share my thought that, if you recommended to a family, I do not think this surgery is useful, and the family says, we want the surgery, you as a surgeon would, if you feel it's not appropriate, you would not be forced to do it. And yet for some reason, we in medical care seem to feel that if the family says, we need CPR, that we're obligated to do it. So I think I'm old enough that I didn't grow up with some of the shared decision-making, concepts in my training. And I just feel that it's really important, as Wayne was saying, that we kind of set the line and say, this is not appropriate. I'm glad that Harborview has the futility concepts. I think that's very helpful to you all there. I just wanted to add that I put in reference to Sudor in JAMA from 2009. And that article really, really helped me to understand the other side of it. Even when the family knows it's futile, that sometimes they just want something done. It's so much easier to say, do something than to say, don't do anything.
Thank you for that. Anyone else have comments before I wrap up?
Katie, have you asked the trainees, the surgeons, you know, your peers and trainees, how come they aren't as comfortable with making recommendations about this when they are comfortable with recommending or not recommending a major surgery?
I haven't. And actually, I think what would be more interesting to me would be to ask fully trained surgeons. You know, my intention is to sort of bring this topic out to the trainees early so that I can get them thinking about it before they become ingrained with our typical culture. But there's a difference even with the attendings. And I think maybe it's just because we're trained to think about those, you know, should we offer surgery, should we not? But no one really talks about should we offer CPR or not.
Yeah. Well, it might be interesting to do both, to, you know, interview seasoned surgeons and also trainees to see if there's a generational trend or difference. Like Pam Davies, I'm old enough to have been around long enough to actually see things change fairly dramatically. Our internal medicine trainees are far more comfortable bringing up code status discussions than even 10 years ago. And not all of them are good at it yet, but most of them are pretty good at it. So there may be a generational difference.
I would say that there's certainly a generational difference with regards to buy-in for surgical palliative care, 100%. People, younger surgeons, medical students are really interested in incorporating this into their practice. So I wanted to just sort of wrap up with this. And I want to acknowledge that probably some of the audience members are wondering why a surgeon would make code status discussions their soapbox. And this is my grandfather and me. And my grandfather, Joe, he died in a Michigan hospital in the middle of the night. And received non-beneficial CPR. And because I have the clinical experiences that I've had, I envision his end of life ritual. And 27 years later, that still breaks my heart. And I know that if someone took the time to have a code status discussion with him, a man who avoided all medical personnel, hospitals, everything till his lymphoma was coming essentially out of his skin, and made a treatment recommendation in line with his values, I think he would have died in a very different manner. And so I'll close in a similar way to how we opened, with an added call to action. I think we need to give patients the choice to decide what their death ritual will look like. And the default option is certainly not one size fits all and needs to be individualized. So thank you again to everyone. The discussion was amazing, and I wish we had another 2 hours to fully discuss everything that was brought up. This is the survey code. Please, if you have a minute, fill that out. I would greatly appreciate it. Thank you so much to everyone who attended.
Thank you so much, Katie.
Hey, Katie.
Yes.
Oh, it's Caroline. Hey, nice, very nice presentation. Thank you so much. It's such a good topic. I don't know if you saw Annie's comments in there, and I'm wondering if in the future having a small piece at least about trauma-informed care, which is funny, trauma in a different way, but talking about kind of the cultural piece there and cultural responsiveness, just as something to consider for that, adding that caveat there.
Absolutely. Thank you for that. Yeah, I'm just now scrolling through all the comments. Yeah, that is definitely a great suggestion. Thank you for that.
Yeah, yeah. I mean, I've been having a really, Erica Pantanote and I have been having this email discussion and thinking about doing some paper writing on this topic, but kind of thinking about the moral distress piece, and is there kind of inherent racism in that, and what we offer, when we make informed recommendations, and how discrimination plays into that. So, but anyway, but otherwise, I think it's so great. I loved your slides, by the way, also. Beautiful, beautiful slides that are nice, crisp and clean and not too much stuff on them. That was fabulous.
Thank you. And thanks for bringing that up. I think that is a huge gap in the literature. I think the literature very clearly demonstrates that survival is worse for non-white patients, and then it sort of ends there. It doesn't like go further into like why is that?
Yeah, and I do think if you could, and if there is all, there is, I know the data about also, I feel like the multi-organ failure, the I don't know if you would need to do your own calculations, like on dialysis. I was thinking about this current patient, and trying to communicate, like when you start adding all of those numbers together, what does that survival look like, like, is there some way you can add those pieces? I don't know if there's a different kind of scoring system out there, or where you can start to add those components and look at the additive compilation of that. That would be amazing.
Yes, and sort of more a qualitative outcome study as well. That's a huge gap. Like, okay, great, folks have survived. Maybe they've survived with some neurologic disability, but maybe their quality of life is excellent.
Right.
I don't know.
Yeah, completely. Yeah, definitely a lot of missing gaps there. All right, I gotta run. Good to see you virtually.
You too.
Bye.
Katie, these grand rounds are recorded, so give us this talk again in 2030, and I bet you'll be surprised how much has changed, maybe in ways that you wouldn't have predicted or expected.
True, yeah.
But it'll be fun for you to watch it in 2030 and say, wow, that was kind of antique, or wow, this has gotten even worse.
It's definitely a topic that the Geri Clinical Council, we've been talking about, especially with regards to perioperative code status discussions, and sort of how are we going to do an educational outreach here at Harborview to get everyone on the same page.